going to have amazing things. We have Gilbernovsky with his CICU series. We have the ECG series going on every other week in English. We have one more talk from Dr. Silverman. We have Dr. Mary Cohen, and we are continuing to have Dr. Anderson with Dr. Diane Spicer and all of these amazing panelists. And we are going to have the fetal series as well, talking about intervention in the fetal life. This is going to be amazing. This is going to be a little bit later than usual because of the holy month of Ramadan, but we are going to send everything to all of you from by email, so you're not going to miss any of our activities. Thank you very much, guys. Please enjoy. Thanks for all the panelists of today, and I'm sure this is going to be a great session as usual.
Ladies and gentlemen, it's a pleasure for me to be with you again, and once more I'm going to be joined by Diane Spicer, and Diane has prepared several videos for you on this occasion to illustrate the features of straddling valves. I realize that I've neglected to tell you over the past few weeks that Diane is now appointed with an academic position at All Children's Hospital in St. Petersburg, Florida. And we're indebted to the support she's receiving from All Children's in St. Petersburg, which nowadays is part and parcel of Johns Hopkins University. So with that preamble, I'll get started. What we're going to be talking about today is straddling valves. In order to understand this, we have to differentiate between atrioventricular valves and arterial valves. That is because there is a difference between straddling and overriding. So I'm going to start off by emphasizing these differences and how they relate to what we describe as straddling, what we describe as overriding. Having done that, I'm going to differentiate the different features of the mitral and tricuspid valves when they straddle and or override. And then we're going to point out the key point here is not only to differentiate between the mitral and tricuspid valves, but to understand whether these valves are straddling and overriding in the setting of right-handed as opposed to left-handed topology. And that, of course, is because the mitral valve is a left-sided structure when we have right-handed ventricular topology, but in genetically corrected transposition, where we have left-handed topology, then you are all aware mitral valve is a right-sided structure. I'm going to discuss with you whether common valves straddle. As you see, I have that as a question. And very shortly, I'm going to show you that a common valve does not always straddle. And that is particularly important in the context of today's discussions. And finally, I'm going to look at the situation in which we have a solitary atrioventricular valve, which produces a biventricular connection, but that solitary valve is not a common valve. And it is that combination that gives us this rare situation, which we can consider as being the uniatrial and biventricular connection. So we have a lot to get through this afternoon, so let's get started. And as I intimated, we have to recognize the difference between an atrioventricular valve and an arterial valve. They, of course, have similarities. They both have leaflets. And I like to describe the moving components of both sets of valves as the leaflets. And this is important because those leaflets guard junctions. Of course, the atrioventricular valves guard the atrioventricular junctions, the arterial valves guard the arterial junctions. But today, we need to concentrate on their differences. And the major difference is that the atrioventricular valves also have tension apparatus. And it is that feature that permits us then to distinguish between straddling and overriding. And that is because it is the arrangement of the tension apparatus that determines the presence or absence of straddling. So we describe straddling when the tension apparatus crosses the septum so as to be attached in both ventricles. We then recognize that the junction of such a straddling valve usually, but not always, overrides the crest of the muscular ventricular septum. That means that the overriding junction is then shared between the ventricles. And in this context, of course, since the arterial valves lack tension apparatus, they can only override, whereas atrioventricular valves can both straddle and override. So we now need to distinguish the junctions themselves as we describe the atrioventricular valves. It seems an obvious point to make that the right valve guards the right atrioventricular junction, the left valve guards the left atrioventricular junction, whereas a common valve guards both atrioventricular junctions. In other words, a common atrioventricular junction. So how do we distinguish between right, left, and common junctions? Well, let me show you some pictures to illustrate that point. I hope you'll immediately recognize that here I am showing you the essence of the commonest form of what we call tricuspid valvar atresia. And in tricuspid valvar atresia, we have a left atrioventricular valve. It is a solitary atrioventricular valve, but it is a left valve, and it is guarding the left atrioventricular junction because the atrial septum is inserted into the base of the ventricular mass in such a way as to sequestrate the cavity of the right atrium from the persisting left atrioventricular junction. And that is what we describe as absence of the right atrioventricular junction. And this is the commonest form of tricuspid valvar atresia. Compare that with one of the situations we see in hypoplastic left heart syndrome, because now we have a right atrioventricular valve. And this right valve is guarding the right atrioventricular junction. Why? Because again, the atrial septum is attaching to the base of the ventricular mass in such a way that it sequestrates the cavity of the left atrium from the ventricular mass. So this is absence of the left atrioventricular connection, giving us again a solitary atrioventricular valve, but now a right atrioventricular valve guarding the right atrioventricular junction. But here we have a common atrioventricular valve. Why is that? Because the common atrioventricular valve is guarding both the right and the left atrioventricular junction. Now you recall, I asked the question, do atrioventricular valves always override and straddle when they are common? And in this instance, the common atrioventricular valve is exclusively connected into the dominant right ventricle, but it is not straddling. The cords are attached to the crest of the muscular ventricular septum, but they do not cross the crest of the septum. So here we have override in the absence of any straddling, and the valve that is overriding is a common atrioventricular valve. But to complete the picture, let me show you this image, because this time, again, we have a solitary atrioventricular valve, and the valve is straddling and overriding. But look at the position of the atrial septum. The atrial septum in this heart is attached in such a way to sequestrate the cavity of the right atrium away from the base of the ventricular mass. So again, we have absence of the right atrioventricular connection. We have a left atrioventricular valve guarding a left atrioventricular junction. But as I've already stated, this left atrioventricular valve is now straddling the crest of the muscular ventricular septum. And it is this arrangement that produces the uniatrial but biventricular connection. The valve is draining the blood from only one atrium, but it is connected to both ventricles. So these are the definitions we're going to use as we show you all these features of straddling and overriding atrioventricular valves. And the key point is that these valves produce a spectrum. And this spectrum of override determines the specific atrioventricular connections. Because the spectrum is intermediate between biventricular and double inlet. And you see, I have not been specific in the way I describe biventricular or double inlet connections, because the biventricular connections can be concordant or discordant. The double inlet can be to a dominant right or a dominant left ventricle. And these are the spectrums we have to consider. So let me begin by showing you what happens in the setting of straddling of the tricuspid valve with right-handed ventricular topology. So you see to your left side there, the pectinate muscles reaching to the crux, on the right side telling us that we have there a morphologically right atrium. And the right-sided atrioventricular valve is straddling the crest of the septum, shown in purple, and its larger part is connected to the morphologically right ventricle. So this means we have concordant atrioventricular connections in this setting. But the other end of the spectrum is found when we have the same atrioventricular valve, but this time connected along with the other atrioventricular valve in its larger part to the dominant left ventricle. And now the right ventricle is much more incomplete. So in this situation, we have double inlet left ventricle with anterior and right-sided incomplete right ventricle. And this is a heart that you've seen several times before. You're going to see it several times again during today's presentation. It's the Van Meerop heart from University of Florida in Gainesville, where DIANE also functions as their pediatric cardiac morphologist. So in this instance, the right atrioventricular junction is overriding. And we can see its precise connections to the ventricles relative to the cord subtended by the crest of the muscular ventricular septum relative to the right atrioventricular junction. There it is, and it is the cord subtending the septum that determines whether the larger part is connected to the dominant left ventricle, the incomplete right ventricle. And in this instance, the larger part is connected to the dominant left ventricle. So we have double inlet left ventricle. So now DIANE is going to demonstrate again to you this heart with straddling and overriding of the tricuspid valve, and she's going to illustrate the spectrum we have.
We're going to look again at the heart from the University of Florida that has a double inlet left ventricle and concordant ventriculo-arterial connections, or the Holmes heart. There is straddling and overriding of the right atrioventricular valve, and here we see the right ventricle and the interventricular communication. The straddling component of this right atrioventricular valve is along the inlet component of the interventricular septum, with a few tendinous cords within the right ventricle, but the majority within the left ventricle. And if we look at the left ventricle, the right atrioventricular valve in its greater part is committed to the left ventricle, making this a double inlet left ventricle, and those straddling components are along the inlet component of the interventricular septum. It also overrides in its greater part to be committed mostly to the left ventricle. This specimen has concordant atrioventricular and concordant ventriculo-arterial connections. It is cut in 4-chamber view, as we'll see in a moment, so I'm going to demonstrate the topology from the anterior aspect of the heart just to show you that it is right hand ventricular topology, so that if I place the palm of my right hand on the septal surface, my thumb can go in the inlet and my fingers in the outlet. If we look at the short axis of this specimen and into the right atrioventricular junction, when I initially opened this specimen, I thought that there was an atrioventricular septal defect and that it was unbalanced, so that the ventricular septum runs just in this area. And this makes the point that many people refer to this type of ventricular septal defect as the AV canal type of ventricular septal defect. And that is totally a misnomer, because in this particular heart, we see that there are two separate atrioventricular junctions. The right atrioventricular junction, which is guarded by the tricuspid valve, and the left atrioventricular connection, which is guarded by the mitral valve. The atrioventricular valves are supported by their own atrial vestibule, and if you'll note, in this particular case, they are supported at the same level and don't have the normal offset that we typically see with relationship to the atrioventricular valves. And this is secondary to the malaligned muscular ventricular septum, which is here relative to the atrial septum. In this particular case, the tricuspid valve, which is a bit dysplastic, straddles and overrides the ventricular septum. Here is a papillary muscle supporting the tricuspid valve within the morphologically left ventricle. This is the crest of the muscular ventricular septum, and you'll see that in cases with concordant atrioventricular connections like this case, the interventricular septum joins the atrioventricular junction in the posterior inferior quadrant, so that it does not reach the crux of the heart or extend to the crux of the heart. The atrioventricular node will be at the junction of the ventricular septum and the atrioventricular junction along this posterior inferior part of the muscular ventricular septum, secondary to the septal malalignment. The bundle branches will then run astride the crest of the muscular ventricular septum. I need to mention that the size and morphology of the right ventricle in this particular spectrum of hearts will depend on the degree of override, so that these specimens can have biventricular atrioventricular connections or progress all the way to those with a double inlet left ventricle. And this also will reflect what the surgeon decides to do when repairing these hearts.
So what you have now seen is straddling and overriding the tricuspid valve. But now we want to emphasize the fundamental difference between straddling and overriding of the tricuspid valve as opposed to straddling and overriding of the mitral valve. And that is because, as you have now seen, the tricuspid valve overrides between the ventricular inlets. It overrides the caudal part of the muscular ventricular septum. The mitral valve, in contrast, overrides into the outlet of the morphologically right ventricle. So here is another picture of straddling and overriding of the tricuspid valve. You see, it's a 4-chamber cut. There is the right atrioventricular junction. And there it is straddling and overriding between the inlets in this heart, which has concordant atrioventricular connections. This is a heart that has the so-called Tausig-Bing malformation. And I'm showing you the outlet view of the morphologically right ventricle. And there you see the mitral valve, which is not only overriding, it is also cleft, but it's overriding through an interventricular communication in subpulmonary position. The valve is overriding into the outlet of the morphologically right ventricle.
We're going to view this beautiful heart from the University of Florida once again, just to show us the spectrum that we have within these hearts with straddling and overriding of the tricuspid valve and right hand ventricular topology. Here we can see the windowed right ventricle and the interventricular septum. So if I place my right hand on the interventricular septum, my thumb goes to the inlet and my fingers to the outlet. So this indeed does have right hand ventricular topology. Also from the anterior aspect, we'll note that there are concordant ventriculo-arterial connections so that the pulmonary trunk arises from the right ventricle and the aorta from the left ventricle, and they do spiral in normal fashion. Looking within the right atrium, again we see our right atrioventricular junction and the right atrioventricular valve. The interventricular septum runs across the entire length of that right atrioventricular junction, and there are tension apparatus supporting the right atrioventricular valve within a portion of the right ventricle and along the right side of the interventricular septum, with the majority of those connections along the left side of the interventricular septum and within the left ventricle. Hearts within this group of straddling and overriding of the right atrioventricular valve have different degrees of straddling and overriding, and this will decide where any particular heart falls within the spectrum, so that this specimen was initially diagnosed as a double inlet left ventricle. So they were stating that more of this right atrioventricular valve was committed towards the left ventricle, and it falls into double inlet left ventricle with concordant ventriculo-arterial connections. In other words, known as the Holmes heart. The size of the right ventricle will determine what type of clinical and surgical management this patient may have. The atrioventricular septal malalignment also displaces the conduction axis because the interventricular septum does not reach the crux of the heart, so that the atrioventricular node will arise where the muscular ventricular septum meets the atrioventricular junction. This specimen is as a result of cardiac transplantation, and we'll note that the majority of the atriums and their appendages along with the arterial trunks have been previously removed. The right atrium is hypertrophied, and we can recognize the pectinate muscles extending around the majority of the right atrioventricular junction, noting that this is a morphologically right atrium. The majority of the left atrial vestibule and its appendage have been removed. Just looking at the specimen, you can already appreciate that the right atrioventricular junction is much larger than the left. This patient also had pulmonary stenosis and a very dilated aorta, with both arterial trunks exiting the dominant right ventricle. Within the inlet of the right ventricle, the tricuspid valve is present with papillary muscle and septal attachments. The right ventricle has coarse apical trabeculations and is quite hypertrophied in this particular case. The topology is right hand ventricular topology, so that I can place the palm of my right hand on the septal surface with my thumb in the inlet and my fingers in the outlet. The outlet component has been a bit chopped up in this case, but here is the aortic valve and the pulmonary outlet is here. It's very stenotic and just posterior to the aorta. Looking within the ventricular chamber or the dominant right ventricle, there is a component of the mitral valve that is straddling and overriding the septum, and we'll note that the straddling and overriding mitral valves will straddle into the outlet of the morphologically right ventricle. When we look at that left atrioventricular junction, there is a smooth vestibule, so this was a morphologically left atrium, so that there are concordant atrioventricular connections. The interventricular septum lies here, and if we follow it, it extends to the crux of the heart. The mitral valve straddles in its lesser part towards the right ventricle, with the majority of that valve committed to the left ventricle. So this is one heart in the spectrum of what we can see with straddling mitral valve. The majority of the valve committed to the left ventricular side with a smaller component to the right, and the end of that spectrum would be to a double inlet right ventricle. Let me again point out that the interventricular septum does reach to the crux of the heart, so that the atrioventricular conduction axis would be in its normal position at the apex of the triangle of Koch.
Note of the influence of ventricular topology. Because what you've already seen is that if we presume we have usual atrial arrangement, and all the hearts we're going to show you today have usual atrial arrangement, when we have right-handed topology, the tricuspid valve is straddling and overriding into a right-sided, morphologically, right ventricle. The mitral valve, however, when it straddles and override, will be straddling and override from a left-sided left ventricle. When we have left-handed topology, the situations are mirror imaged. So now the tricuspid valve will straddle and override it into a morphologically right ventricle that is left-sided, whereas the mitral valve will straddle and override relative to a morphologically left ventricle that is right-sided. And of course, the extent of these spectrums will again dictate the atrioventricular connections. So you've already seen what happens when we have straddling tricuspid valve with right-handed ventricular topology. DIANE has shown you that when the overriding junction is mostly to the right ventricle, you have concordant atrioventricular connections. When the overriding junction is mostly to the left ventricle, you have double inlet left ventricle, and that right-sided incomplete right ventricle is right-sided. And always, when we have incomplete right ventricles, they're positioned anterosuperiorly within the ventricular mass. So now, what we're going to look at is what happens when we have straddling tricuspid valve in the setting of left-handed ventricular topology. And as you all know, the essence of usual atrial arrangement with left-handed ventricular topology is, in most instances, congenitally corrected transposition. So what we're going to see this time, again with straddling of the tricuspid valve, is another spectrum. And we're now going to move from discordant connections once more to double inlet left ventricle. But this time, the right ventricle is going to be left-sided. It's always going to be a little incomplete when we have override of the atrioventricular junction. Because we have essentially discordant atrioventricular connections, always the conduction axis is going to be abnormal. So we're going to find the atrioventricular node positioned anterolaterally within the right atrioventricular junction. But this is the spectrum that we're going to be looking at. Now, note the colors. The morphologically right chambers are shown in purple. Morphologically left chambers are shown in blue. So here we have discordant atrioventricular connections, but with a little bit of straddling and overriding of the left-sided morphologically tricuspid valve. And when most of the atrioventricular junction in this instance is connecting the left atrium into the left-sided morphologically right ventricle, we have discordant atrioventricular connections. But we have that same spectrum whereby the tricuspid valve is overriding a ventricular septum that now is malaligned and is away from the crux. So the tricuspid valve is once more overriding the inlet component of the muscular ventricular septum. The right ventricle is always going to be hypoplastic, but it's going to be much more hypoplastic when we have this situation at the end of the spectrum. Only a small part of the junction now straddling into that right ventricle, the larger part into the big ventricle, giving us double inlet left ventricle, the incomplete right ventricle now being left-sided, but still positioned anterosuperiorly. Always the incomplete right ventricle is carried on the shoulder of the ventricular mass. So this is the spectrum we're going to be looking at. This is a drawing that shows you more or less the middle part of the spectrum. There you see the straddling tricuspid valve. We're going to expect there to be an anomalous atrioventricular node, and the conduction axis will pass anterocephalad relative to both the pulmonary valve, as almost always we have discordant ventricular arterial connections, and the ventricular.
You can see that there are multiple epicardial adhesions, so this patient had previous surgery. Also, we'll note that it is a product of cardiac transplantation. The majority of the atriums are absent, as are the majority of the arterial trunks. Secondary to the previous surgery, the pulmonary trunk was ligated, and you can see that it lies in a posterior and rightward location relative to the aorta, which has a prosthetic valve in place. Looking at the right atrioventricular junction, within the atrium we see a few remnants of pectinate muscles, which tells me this is a morphologically right atrium. The coronary sinus is in this location. The inlet to this left-sided ventricle is a morphologically mitral valve with only papillary muscle attachments and no attachments to the interventricular septum. The left ventricle will always have a mitral valve in its inlet, so that this right-sided ventricle is morphologically left with its fine crisscrossing apical trabeculations. There is a smooth septal surface towards the outlet, and you'll note that the interventricular septum has also been sectioned here, and I'll try my best to hold it together while looking at the anatomy. The pulmonary valve lies in the outlet of this right-sided morphologically left ventricle, so we also have discordant ventriculo-arterial connections. So there is discordant atrioventricular and discordant ventriculo-arterial connections. This specimen is consistent with congenitally corrected transposition. There is a ventricular septal defect, and already we can appreciate that there is slight override and some straddling of the right-sided atrioventricular valve along the posterior inferior aspect of the defect. Looking at the left-sided remnants of the atrium. The vestibule is smooth, and this is consistent with a morphologically left atrium. You'll also note that there was a surgically created atrial septal defect. Guarding the inlet of this left-sided atrioventricular junction is a morphologically tricuspid valve. There are attachments to the papillary muscles, and along the crest of the ventricular septum, multiple chordal attachments to the septum. The left-sided ventricle is a morphologically right ventricle with coarse apical trabeculations. The outlet component of this left-sided morphologically right ventricle has a complete subarterial infundibulum, and the aorta did exit this left-sided morphologically right ventricle, but there is now a prosthetic valve in its place. So again, on the left side of the heart, we have a discordant atrioventricular and discordant ventriculo-arterial connection. At this point, I can also show you that there is left-hand ventricular topology. So I can place only the palm of my left hand on the septal surface with my fingers in the outlet and my thumb in the inlet. The ventricular septal defect is nicely seen from this view with those chordal attachments along the crest of the septum. If we look at that four-chamber cut across the septum, it's easy to appreciate the straddling cords and the slight override of this left-sided tricuspid valve. Because the septum does not reach the crooks, the atrioventricular conduction axis arises from an anterior lateral node in the right atrioventricular junction, so that a long non-branching bundle runs in anterior cephalic position to the pulmonary valve and the ventricular septal defect, and it will encircle the pulmonary valve or orifice to reach and branch on the anterior superior part of the muscular interventricular septum.
So what you've seen now is straddling and overriding of the tricuspid valve in the settings of right-handed and then left-handed ventricular topology. We're now going to do the same thing when it is the mitral valve that is straddling and overriding. And remember, the mitral valve straddles and overriding through to the outlet of the morphologically right ventricle. So when we have right-handed ventricular topology, this time we're going to have a spectrum from concordant to double inlet right ventricle, because the valve is moving into the dominant right ventricle. And that means the left ventricle is now going to be incomplete and left-sided, but always it's going to be tucked in the hip pocket of the ventricular mass. And since the valve is straddling and overriding across it, and since it's going into the outlet, the septum will retain its connection at the crux of the heart. So, right-handed ventricular topology, we will still expect to find a regular conduction axis. And this is the arrangement. I've shown you a picture of it already. We find it frequently in the setting of the Tausig Bing malformation. So I show you the pictures. You see the colors are matching up, blue to blue, purple to purple. And in this instance, a small part of straddling and overriding, the larger part of the mitral valve going into the left ventricle, we have concordant atrioventricular connections. At the other end of the spectrum, the larger part of that straddling and overriding mitral valve has now moved into the big ventricle, leaving but a small part of it entering, or rather coming out of the incomplete ventricle, which is now tucked away in the hip pocket of the ventricular mass. We have double inlet right ventricle. The incomplete left ventricle will be left-sided and posterior.
We're going to go back and review a couple of hearts that we looked at, but do it in sequence this time so that you can see the spectrum of straddling and overriding of the mitral valve. So here's our right atrioventricular orifice, and here is the left. The mitral valve is straddling and overriding the interventricular septum, with its greater part being supported within the posterior inferior morphologically left ventricle. The lesser part is being supported by a papillary muscle and some tendinous cords within the dominant right ventricle. This dominant right ventricle also had a double outlet with pulmonary stenosis. And here is our tricuspid valve orifice, which is of good size. The lesser part of the mitral valve is committed to this dominant right ventricle with the tendinous cords and small papillary muscle supported within this dominant right ventricle. So the lesser part of the mitral valve is committed to the right ventricle. This specimen also had a double outlet right ventricle with pulmonary atresia, if you remember correctly. So we're going to move just to the next heart, looking immediately into the dominant right ventricle. And here you can nicely see the spectrum of where the degree of straddling and overriding can take us. So that here's our right atrioventricular valve, and here is the left. So that the greater part of this left atrioventricular valve is supported within this dominant right ventricle. So we end up with a double inlet to the right ventricle, as opposed to the last heart that we looked at, where the lesser part of the left atrioventricular valve was supported within the right ventricle. This specimen also has a double outlet, but with both outlets very widely patent. The hypoplastic left ventricle, in this case, shows us the degree of hypoplasia between the last heart and this heart. The last heart had a fairly nice sized left ventricle, and here we have a tiny hypoplastic left ventricle. The left atrioventricular valve in its greater part is supported within that right ventricle, and the portion that is straddling and overriding the interventricular septum is quite small. So this depressed area is where the mitral valve is adherent to the crest of the interventricular septum. So a small portion committed to the hypoplastic left ventricle, but not allowing any blood into there, secondary to it being adherent over the interventricular septum. You can see portions of the valve supported within this tiny left ventricle on the hip pocket of the heart, and how much smaller this left ventricle is than the previous heart we looked at. So hopefully these two hearts can show you the spectrum of straddling and overriding of the mitral valve.
So now we're going to complete the sequence of ventricular topology, straddling tricuspid, straddling mitral valves, and we're going to look at what happens with straddling of the mitral valve in the setting of left-handed ventricular topology. Again, going to have a spectrum because we're talking left-handed ventricular topology. Because we're talking about straddling of the mitral valve, we're going to have discordant atrioventricular connections at the better end of the spectrum. We're going to have double inlet at the other end, but because the mitral valve is moving into the right ventricle, this time we're going to have double inlet right ventricle. The left ventricle, however, now, because we have left-handed ventricular topology, will be right-sided, and at the end point of the spectrum, it will be tucked in the hip pocket on the right side. But because we have discordant atrioventricular connections, we're going to anticipate the abnormal conduction axis. We're going to expect there to be the abnormal node we've already seen in the right atrioventricular junction. But in this setting, on occasion, we can have what is called the sling, because when there is extreme straddling, the back part of the septum can remain at the crux of the heart. So then we can have two atrioventricular nodes. So let me show you the pictures. Again, you will recognize that we're talking about left-handed topology because the colors don't match up. So blue on the top as you look at it, the left side is going to purple. And this, of course, is the right side of the heart. The left side of the heart, we have the morphologically left atrium connected to the morphologically right ventricle. And here we have minimal straddle and override of the mitral valve. There is the tension apparatus coming through the ventricular septal defect, and it's going to be an outlet ventricular septal defect. The larger part of the mitral valve retains its attachment to the morphologically left ventricle, so we have discordant atrioventricular connections. Again, we have the spectrum, and at the extreme end of the spectrum, the larger part of that straddling and overriding mitral valve has made its way into the dominant right ventricle. There's a little bit of it left behind, and that is now within the incomplete left ventricle. And because it is left-handed topology, that incomplete left ventricle is in the hip pocket of the ventricular mass, but now it is right-sided. The larger part is going into the big ventricle, which is the dominant right ventricle. So we have double inlet right ventricle, to emphasize the point, with right-sided, posterior, incomplete left ventricle.
This specimen is a product of cardiac transplantation, and as you all remember, the majority of the structures at the base of the heart are removed. So here we can appreciate that we have usual atrial arrangement with a morphologically right atrium and atrial appendage to the right, and a morphologically left atrial appendage and atrium to the left. This patient also had a double outlet right ventricle with the aorta almost directly anterior to this very large pulmonary trunk and pulmonary valve. Looking into the right-sided atrioventricular junction, we can already appreciate that there is straddling and overriding of this right atrioventricular valve. Here we see the interventricular septum running the entire length, or running beneath the entire length of this right atrioventricular junction. On the right, guarding the inlet to this right-sided ventricle, is a morphologically mitral valve, so we have only papillary muscle attachments and no attachments of this mitral valve to the interventricular septum. On the right side of the heart, there is a morphologically left ventricle with its crisscrossing apical trabeculations at the apex and a smooth septal surface. So we have discordant atrioventricular connections at this point. The mitral valve is straddling and overriding the more anterior portion of the ventricular septum and towards the outlet component of the left-sided ventricle. So you can see this large ventricular septal defect. The mitral valve also has a true cleft, which is pointing towards the outlet component of the ventricle rather than at the interventricular septum. The left-sided morphologically left atrium has a morphologically tricuspid valve guarding the inlet to this left-sided morphologically right ventricle. So there are, of course, apical trabeculations and a trabeculated septal surface. The atrioventricular connections on the left side are also discordant, with a left atrium connected to a morphologically right ventricle. In this case, the right ventricle will only permit the palm of my left hand to lie upon its septal surface, with my thumb in the inlet and my fingers in the outlet. So there is left hand ventricular topology in this case. The inlet is guarded by a very dysplastic tricuspid valve that is partially adherent to the crest of the ventricular septum or along the inferior portion of the ventricular septal defect. There's also an Ebstein's malformation where this portion of the tricuspid valve failed to delaminate and the hinge point is rotated downward rather than being at the usual hinge point at the atrioventricular junction. The mitral valve is straddling with a small papillary muscle towards the apex and a larger papillary muscle towards the outlet component of this left-sided morphologically right ventricle, so that the pulmonary valve lies in between or the pulmonary outlet, I should say, lies in between the tricuspid valve and this straddling component of the mitral valve. The aorta is anterior to the pulmonary trunk and is supported by a complete muscular infundibulum. So that if you imagine extreme override of this mitral valve, this right ventricle would become extremely small and you would have more of a double inlet right ventricle on the left side of the heart, with the rudimentary right ventricle being more in the anterior pocket of the ventricular mass. So imagine the spectrum of increased straddling of this mitral valve from the right side of the heart and this right ventricular component on the left becoming increasingly smaller within that spectrum. With hearts that have congenitally corrected transposition, so discordant atrioventricular and ventricular arterial connections, we know the conduction axis lies in an abnormal anterior position. This specimen is a close cousin in that we have discordant atrioventricular connections with a double outlet right ventricle. And when you have a double outlet right ventricle in this particular situation, it allows for better alignment of the atrial and ventricular septums, so that in some cases you can have the septum reaching the crux of the heart, whereas in cases with congenitally corrected transposition that is not possible. So here the interventricular septum reaches the crux of the heart and there is a fibrous component where the tricuspid valve and the mitral valve are in fibrous continuity. In this particular case, you can have both an anterior and a posterior AV node make contact with the ventricular conduction tissues, and this is known as the Munkenberg sling. So that in cases with discordant atrioventricular connections and a double outlet right ventricle, there's a better chance for atrioventricular septal alignment.
So what we've looked at now is the spectrums that exist when we have straddling or overriding of either the mitral valve or the tricuspid valve, and we've looked at that in the setting of either right-handed topology or left-handed topology. And we've been working out sequences, and those sequences produce spectrums. And the point now, exactly those same spectrums can be found when we have a common atrioventricular valve, depending on which way it overrides, straddles. And so again, we will have spectrums from concordant or discordant connections to double inlet right or left ventricle, but this time through a common atrioventricular valve. Now, we can't show you all of these spectrums, so what we're going to do, we're going to show you the spectrum when we have right-handed ventricular topology and when it is the right ventricle that is the dominant ventricle. And so what DIANE is going to show you is that this spectrum extends from right ventricular dominant atrioventricular septal defect to double inlet right ventricle. And because the right ventricle is now dominant, The incomplete left ventricle in right-handed topology will be posterior, tucked away in the hip pocket, the posterior leftward hip pocket of the ventricular mass. And Diane's now is going to show you that spectrum of straddling and overriding with a common atrioventricular valve.
In this segment, we're going to look at a couple of hearts to show the extreme variation in those specimens that have a common atrioventricular junction. In this specimen, which was as a result of a transplant, so that you can see the majority of the atriums and the arterial trunks have been previously removed, there is a common atrioventricular junction with right ventricular dominance. There are concordant atrioventricular and ventriculo-arterial connections. The pulmonary trunk arises in its usual position anterior to the left of the aorta, and the aorta is unwedged secondary to this common atrioventricular junction. Looking into the atrioventricular junction, there is a common atrioventricular valve that is separated into right and left components because the bridging leaflets were adherent to one another across the crest of the septum, so that the right side has its own orifice and the left its own orifice as well, which is the hypoplastic orifice. Looking at the four-chamber view and the inferior surface of the heart, we can see the dominant right ventricle and the small left ventricle. So this is the interventricular septum. The inferior bridging leaflet is entirely adherent across the crest of the septum, so that we have concordant atrioventricular connections in this particular case, with the greater part of the atrioventricular junction committed to the right ventricle. And you can see the right atrioventricular valve here in its dominance and the smaller component of the left atrioventricular orifice to this common atrioventricular valve. The second heart within the spectrum also has a common atrioventricular junction with a dominant right ventricle. This heart is also as a result of cardiac transplantation, so the majority of the atriums and the arterial trunks have been removed. There was pulmonary atresia in this particular case, with the aorta exiting the right ventricle, but following transplantation, the pulmonary trunk could not be identified. The morphologically right atrial appendage lies to the right, and the morphologically left atrial appendage with its narrow junction and smooth vestibule is to the left. On this short axis view, we can easily appreciate the common atrioventricular valve. The interventricular septum is very difficult to see as there is extreme unbalance in this situation, so that the right component of the common atrioventricular valve is dominant, as is the right ventricle. So the interventricular septum, we'll see, lies just in this area. On the four-chamber view, the right ventricle is the dominant ventricle. You can see the coarse apical trabeculations and the dominant component of the common atrioventricular valve, so that there were concordant atrioventricular connections in this particular case, with both of the atrial chambers mostly committed to the right ventricle. The interventricular septum is here, and the tiny slit-like left ventricle, which would be in posterior inferior position, is here. The common atrioventricular valve is mostly composed of the right component. Here is the inferior bridging leaflet that is adherent across the crest of the ventricular septum and effectively blocking the egress of blood into the left ventricular chamber. If I fold this leaflet back, which was cut, you can see that it is entirely adherent to the crest of the interventricular septum. If we look at the opposite side of this specimen, again, we see the right dominance, the interventricular septum, and the small left ventricle. In many cases with a dominant right ventricle and common atrioventricular valve, there is a solitary papillary muscle within the left ventricle, as we see in this case, and you can see that it also is virtually stuck to the septum with some of the cords that were supporting this superior bridging leaflet. The superior bridging leaflet as well is mostly adherent to the crest of the ventricular septum, so that the inlet is virtually blocked, with the only way to get blood into that ventricle via this residual ventricular septal defect beneath the superior bridging leaflet. So this heart represents the extreme end of the spectrum, where we have a double inlet to the dominant right ventricle with a common atrioventricular valve.
So to complete the sequence, we have to return to that rarest of situations where we have straddling and overriding of atrioventricular valves. And this is that strange combination that we call the uniatrial but biventricular connection. I've shown you a photograph of the heart. It is the combination of absence of an atrioventricular connection with straddling and overriding of the solitary atrioventricular valve. And of course, this produces one form of double outlet atrium. I'm not particularly fond of the term double outlet atrium, because whenever we have overriding valves, we always have double outlet of the atrium from which they take their origin. So when we have the uniatrial but biventricular connection, it can involve either the right or the left-sided valve, and it can exist with both forms of ventricular topology. So if you understand the sequence we have been talking about today, you will understand all of these variations. In fact, we don't have a heart with this combination to show you, but the dominance of either ventricle can vary. So again, I'm going to show you the concept. And this, in fact, is a drawing of the heart I already showed you. It has absence of the right atrioventricular connection. So we're talking about, to all intents and purposes, tricuspid atresia. And in this drawing, there is right-handed ventricular topology. So this would be tricuspid atresia. But there is straddling and overriding of the solitary atrioventricular valve. And in this setting, I emphasize again, it is a left atrioventricular valve because it is guarding the left atrioventricular junction. As you see, it is straddling and overriding between a left-sided, morphologically left ventricle, a right-sided, morphologically right ventricle. So here we have straddling and overriding in the setting of tricuspid atresia with right-handed ventricular topology. But I emphasize again, you can have this very rare combination in the setting of absence of either the right or the left atrioventricular connection, and you can have it with either right-handed or left-handed ventricular topology. But to finish off, we have to emphasize that what I have been showing you thus far and what DIANE has been demonstrating to you is rules. And as you are all well aware, on occasion, rules can be broken. But if a heart is breaking the rule, if you know what the patterns are, then you should be able to recognize what is going on. And DIANE now is going to show you a very interesting heart, which does indeed break the rules, but is still understandable on the concepts that we have been placing before you.
This specimen, with straddling and overriding of the mitral valve, has the anterior wall of the right ventricle, partially removed, and this allows me to show you that there is right hand ventricular topology, so that my thumb is in the inlet, my palm is on the septal surface, and my fingers are in the outlet. This specimen has juxtaposed atrial appendages to the right of the arterial pedicle. So here is the tubular left atrial appendage and the blunt right atrial appendage, which has in part been removed. The specimen has concordant ventriculo-arterial connections, and this is not the typical case. You usually have double outlet right ventricle when you have straddling mitral valve, but here's the pulmonary trunk exiting the right ventricle in the usual fashion, and there's a pulmonary artery band in this case, and the aorta arises from the left ventricle. There is hypertrophy of this morphologically right ventricle, and the inlet of the tricuspid valve has been pushed a bit inferior. The papillary muscle that is partially supporting the mitral valve within the right ventricle lies virtually at the mid-septum, when the usual case is for the mitral valve to straddle towards the outlet component of the right ventricle. If we look at the short axis view from the base of the heart, here is the left appendage with its narrow attachment to the smooth-walled left atrial vestibule, which is extremely dilated, and here are the pectinate muscles around the right atrioventricular junction. The atrial septum is aneurysmally dilated towards the right atrial side, and here is the mitral valve at the left atrioventricular junction. The mitral valve clearly straddles and overrides the muscular interventricular septum, which lies here, and in cases with straddling and overriding of the mitral valve, the muscular interventricular septum does reach the crux of the heart. The mitral valve typically straddles and overrides the more anterior superior portion of the muscular interventricular septum. There is that papillary muscle supporting it within the right ventricle, and looking at the atrioventricular junction, the mitral valve is committed approximately 50% to the right ventricle and 50% to the left ventricle. The left ventricle is of good size, and you can see one papillary muscle here within the left ventricle, and another has been removed. The aorta does exit this morphologically left ventricle so that there are concordant ventriculo-arterial connections. The conduction axis will lie in its usual spot at the apex of the triangle of Koch in their normal position, just as they are within the normal heart.
So what we have been talking about quite some time, we've been seeing a lot of hearts, but there is a sequence that goes through everything we've been talking about. We've been talking about straddle versus override in the setting of atrioventricular valves. Let me remind you again, it is the tension apparatus that straddles, it is the junction that overrides. We've been emphasizing the difference between straddling and override of the mitral valve as opposed to straddling and overriding of the tricuspid valve. And here you must remember that very rarely both of the valves can straddle and override in the same heart, but usually they do not. Usually it's either the tricuspid valve that is straddling and overriding, or it is the mitral valve that is straddling and overriding. We've emphasized to you that the situation changes in the setting of right-handed as opposed to left-handed topology. I've also emphasized particularly the necessity to distinguish between a common atrioventricular valve, which guards both atrioventricular junctions, as opposed to a solitary atrioventricular valve that guards either the right or the left atrioventricular junction. And in that setting, when we have the solitary valve guarding either the right or the left atrioventricular junction, the other atrioventricular connection will be absent, giving us one form of atrioventricular valvar atresia. If you put all of this together, then I do believe we've shown you the way in which you can take care of all the hearts in which you find straddling and overriding of the atrioventricular valves.
Thank you very much, Dr. Anderson and Dr. Diane. It was very nice. I think we have today Adrian, that he has some hearts to show. He found some interesting cases to show us, if that's okay.
Is Adrian with us?
Yeah, he was supposed to be. Maybe
I know he was supposed to be. I haven't seen him popping up yet. Are you there, Adrian?
I think we lost him. Okay, soon he is going to connect again. In this meanwhile, Dr. Silverman, do you want to start with your comments as usual? And guys, don't be shy. Please text your questions on Q&A.
Thanks very much, Grace. I was intrigued by this because I thought I had it all squared away. The feature of an AV septal defect is the commonality of the atrioventricular junction. In straddling valves, there are two atrioventricular valve orifices. It seemed that everything was going fine for this, except that in one case, there was no malalignment between the atrial and the ventricular septum in the last case that Diane showed us. I wonder whether one could just put that aside and say that in every case of straddling valve, with one or two exceptions, there is malalignment between the atrium and the ventricular septa.
I don't think that's strictly true, because even if you have, if you think of the spectrum of straddling and overriding of the mitral valve, I mean, what we showed you is that the septum still comes to the crux. So if you look at the atrial septum versus the ventricular septum at the crux, they still come together. So I think it depends on where you are taking your septal malalignment. I think the point to make is that even I agree with you that in the case that she showed, there was a common AV junction, but the larger part of the common AV junction was committed to the right ventricle, but still with the smaller part going into the left ventricle. She then showed you the extreme case in which there was double inlet. So the entirety of the AV junction was going into the right ventricle. And the point we were trying to make was that was override of the common AV valve rather than override of the mitral valve in the setting of where you have separate junction. I think the rules still hold, and I think it is still the case that if you have straddling and overriding of the mitral valve, and you have then the septum comes to the crux, and even in congenitally corrected transposition, that was the case. I think Diane showed you that very beautifully. In the case with left-handed topology, it was the case she showed you with the Epstein's malformation as well. In that case, even though there were discordant atrioventricular connections, the septum did come to the crux, although that heart did also have double outlet right ventricle. So I'm not sure that would always be the case if it was congenitally corrected transposition. But certainly with right-handed topology, I think it is the case that the septum does come to the crux.
Well, Bob, I think this has been an outstanding session as usual, but the concepts here are ones that are going to require review of the whole set of data, because it's not possible for, perhaps if I could consider I have a normal human mind, to actually assimilate all of these things in one setting. The one issue that's interesting of these patients that Diane showed us was the number of patients with this condition that land up getting heart cardiac transplantations. I mean, I think that is one of the issues that I think is certainly worrisome. And I must say that in my career of over 40 years, I have not come across more than a handful of patients with straddling of the AV valves. The interesting thing as an echocardiographer is that the easy thing is to see the chordae tendineae going across the ventricular septum. That is, I think, together with morphology that you have shown us, the real way of looking at straddling valves, and that's the strength of echocardiography. So when you see, as an echocardiographer, a valve straddling across the ventricular septum, you then have to decide, what are you dealing with? Are you dealing with the straddle, or are you dealing with an AV canal? And the rest of the situation becomes quite complex. I think that it's easy to see, and I've seen patients with straddling atrioventricular valves, straddling into a right ventricle of a left AV valve, where because of the malalignment with the septum, the patient looked like there was an AV septal defect because the plane of the septum was out of the plane of the echocardiographic cut.
Well,
so I think that there are problems.
The points you've just made are the precise points we were trying to emphasize. And I think you've hit the nail on the head when you say, if you see straddling of the tension apparatus, you are immediately thinking about an atrioventricular septal defect and a common AV valve. And that was the very point I tried to emphasize throughout, that it isn't the straddling valve that makes it an atrioventricular septal defect. It's the fact that you have a common atrioventricular junction. Correct. And what we tried to show is that on occasion, even that common atrioventricular junction can be exclusively supported by one or other of the ventricles, so you can have double inlet through a common atrioventricular valve. And I think the other point then you've made, if you see straddling an overriding of the right or left atrioventricular valve, you should not presume that then you are dealing with an atrioventricular septal defect.
That is correct.
If you have separate atrioventricular junctions, you do not have an atrioventricular canal. And I think that's what DIANE showed you so beautifully when she was showing the Van Mierop part, because there are still some who say that's an AV canal defect. How the hell can you have an AV canal defect if you don't have an atrioventricular canal? And so the points you make are absolutely key. But I also agree with the point you've made, is that so many of those hearts that DIANE showed you were transplant specimens, and that is because straddling and overriding of the right or left AV valve is a nightmare for the surgeon. And we have Jim QUINTESSENZA there. I see he's unmuted himself. Jim, I'm sure you can talk to this. I mean, it must be a nightmare to you as a surgeon if you are confronted by straddling or overriding of either the tricuspid or the mitral valve, because when the tendinous cords are going through that ventricular septal defect, you can't really close it, can you?
Well, we have a variety of ways of either, fenestrating a patch or cutting the head of the papillary muscle and reimplanting it on the patch. I mean, there are ways of dealing with it, but you're correct. It increases your adrenaline levels considerably as you're trying to figure out what to do. One question I just wanted to ask, and this maybe for Norman, is can you tell that you have a common junction versus a straddling set of valves by echo? In other words, over the years, we've talked about the common junction defining AV septal defects, but can the echocardiographer be sure that he's seeing a common junction echocardiographically? I've never gotten the answer to that question.
Well, I think, Jim, I think I have exactly a case with this issue in mind. And what I think echocardiography shows you is it shows you the atrioventricular valve tissue very well. So you can see atrioventricular valve tissue. And if you see two groups of atrioventricular valve tissue, including one which is straddling, you must assume that there are two atrioventricular junctions. Okay, what I've seen with this is if you take these patients then to CT and you look at the cine CT of this, what you see in cine CT, because it is a synthesized three-dimensional image, what you get is you get beautiful pictures of separate junctions. So I think that your answer to your question is you have to choose the appropriate technique for showing you what you're looking at. The strength of echocardiography is to look at valvar tissue, which you don't see very well with synthesized tissue. And if you want to really see the junction morphology, then of course something like MRI or CT is the way to go on that. So I think that, you know, when you're dealing with these patients today, nobody in his right mind would go to surgery without these ancillary three-dimensional techniques. So I think it's possible to get there, but you know, you have to use the strength of each particular modality of investigation to synthesize the entire picture.
Can I put another question to you there, Norman? Because I mean, when I started off, I tried to show the difference between a right AV junction, a left AV junction, and a common AV junction. And I made the point it was all to do with the attachment of the base of the atrial septum relative to the atrioventricular junction. Now, you are as skilled an echocardiographer as anybody. You've probably been doing it more than most people. In fact, you've probably been doing it more than most people have been alive, because when was it you started? You were at the birth of cross-sectional echocardiography, 1976, wasn't it? When you were at Stanford, when you started doing cross-sectional echocardiography.
74, Bob, don't cut me
74. So if you, as I say, if you trace the base of the atrial septum, do you not think now that a skilled echocardiographer should then be able to distinguish whether you're dealing with a right junction, a left junction, or a common junction?
Well, yes and no, because in the normal set of circumstances, in I think the standard AV septal defect, the septums are in alignment as well. And the key, by and large, in my understanding, is that septal malalignment between the atrial and ventricular junctions is difficult. You see, because the plane of the atrial septum cannot be seen in the same plane. You understand the technical issues that I'm talking about. So yes, I think you can always see where the AV junction goes if it does go to the septum. And in many of the patients that I've seen, including one of the pictures that DIANE showed, there's very little septal remnant. There's a huge, so it becomes extremely difficult to see that. And I mean, I think that, you know, as far as perfection is concerned, echocardiography is not perfect. I remember your great remark of saying you once wanted to change your name to nobody because nobody's perfect. So I think that we just have to realize that, you know, that we can get the majority of the things straight, but I think that there is always going to be a sobering room to understand that one technique is not enough to make this definition. And, you know, unfortunately, the surgeons and the rest of us don't get to see the heart as beautifully as you do, where it's not beating and it's got all those problems. But I think now with 3D reconstruction and printing in this may well be one of the real cardinal values for doing the 3D printing.
You wouldn't even need to do the 3D printing though, would you? Because I agree with you 100% that if you go to a CT scan for sure is going to show whether you have separate AV junctions or a common junction, because with the CT scan and the three-dimensional virtual dissection, then you are going to be able to see the relationship of the junctions. And even if there's an imperforate atrioventricular valve, you would still be able to see whether that imperforate valve was guarded guarding a separate atrioventricular junction. I still remain to be convinced that you need to print it. I think with just looking at it on the computer screen and doing, as long as you do the reconstructions.
Well, you know, there's a new technique called holography, which allows you to establish that with laser light, and you can do that. You can expand it. You can look at this as you are actually in the heart looking up at, you can magnify it to that extent. And it's really quite spectacular, the new technology. The other issue, Bob, that I wanted to say is that, I mean, it's amazing, DIANE, that you've got such a spectrum of these diseases, because I think that's much more than I've seen in my career, to see all of these things. So it's a very rare anomaly, number one. And
I think a lot of it depends on what you find. I mean, Diane, you found a lot of these by looking at the transplant experience at All Children's, did you not? You found them as you've been starting looking at the All Children's archive.
Yeah, I found a few things there that I didn't realize I had. So especially that little tiny heart with the straddling mitral valve that was only partly committed to the right ventricle. So
that was a beautiful specimen. I mean, the two specimens you showed, the specimen you showed of the double inlet right ventricle with the straddling mitral valve, those were absolutely exquisite specimens.
Absolutely.
But the point that Norman's made, I mean, Q, how many transplants are you doing these days?
Well, and the series that we're probably close to maybe 100 and 200 or something like that, but it spans a long time. And I think some of those early specimens, I'm not quite sure we identified exactly what we were dealing with early on, to be honest with you. And that's what DIANE is finding.
I mean, the way that she's able to, I think the presentation she's been doing and the help she's been getting from your guy at All Children's has been spectacular. And to bring, I mean, to see that today, you must have been astounded. If you could see those things as nicely as that in the operating room, you'd be very happy.
Just cut the atriums off and have a look.
I ask a question to you.
That, and then you can suture them back again, Jim. That would be great. Bob, I want to make one.
Let Alan ask a question.
Quick question to the surgeons. I mean, most of those specimens were transplanted hearts.
That's right.
When can you try to repair a heart with a straddling tricuspid valve? When can you do that?
When you take it out.
Is that it? Good answer.
I don't recall, but I mean, I think just to the point we were just talking about with advanced imaging now, cross-sectional imaging, overlaying echo data, 3D echo data on top of cross-sectional imaging, I think, and doing it really virtually or digitally and not really needing a printed specimen, although printed specimens are fine. We just have so much more insight into what we're dealing with compared to 20, 25 years ago. And I think we have now the ability to plan, and we have techniques that, within reason, we can kind of septate hearts, but there are times where it's beyond what we can do, and replacement therapy would be indicated. But I think those are much rarer today as we've gained insight.
I mean, Q, let me ask you, you made the point that you can, if you have minimal straddling the tricuspid valve, you can take the papillary muscle away, you can put it on the other side of the patch, but we all know that for all of those, you can convert them to the Fontan procedure, and is that not a safer option?
Sir, I think it depends on the overall complexity of what else is necessary. So, if we have an isolated VSD with a straddling, tricuspid or even mitral, I think we could deal with that. If you have a lot of other complex morphology, I think single ventricle reconstruction winds up being the better option. So I think we just have to take each case, for what it requires.
Have you had any experience with, how many have you done that, where you've transplanted the tension apparatus and closed the defect?
Oh, not many. I mean, a handful. These are rare, right? And so, it's just when it happens, a lot of times, quite frankly, we find it and we weren't as good at seeing it preoperatively in the past. So a lot of times you open up and you say, oh, this one is special, and you have to create the solution.
I mean,
Can I make a point? We've had at Stanford had exactly this issue, Bob, where the patient came in for a bidirectional Glenn because they were going down a single ventricle pathway, and there was straddling tricuspid tissue. And I think it's much easier when you deal with transplanting a straddling valve that's going to go into a low pressure ventricle than a high pressure ventricle. And so we saw the straddle, and I've had an excellent relationship with Frank Hanley. And I said, look, Frank, I think you can close this VSD and transplant the cords. And that's what he did. He took Gore-Tex cords and put that into the right ventricle. And the patient came off with minimal tricuspid regurgitation of bypass and is living with a 2-ventricle repair and a little tricuspid regurg rather than a double inlet ventricle type of repair.
Yep.
So we've seen that several times, and Hanley actually has written up patients. But I think that, just as Jim had said, that this is the kind of problem where everybody has only a handful of cases for experience. And what, Jim, you should be doing is you should start a pilot study on straddling valves as the congenital heart thing through the American Heart Association is doing, and collect all of these together and see what the surgical experience and the results are. Bob, I have to ask you this most important question. I think you have to move from London to Delphi, because there you can really be the oracle. So I'm going to ask you the oracle question. And the oracle question is, you started off talking about straddling and overriding atrioventricular and ventricular arterial valves. Now, with ventricular arterial valves, we know that there's the 50% rule. In other words, and we've used this all the time. Do we, when we look at atrioventricular valves, also use a 50% rule for describing them as double inlet or straddling valves?
Absolutely. I mean, we spoke about the spectrum, and we presumed you would have, we presumed it was intuitive that you would break that at the midpoint. And what DIANE showed you, and she showed you you've seen, everybody's now seen the Van Mierop part on numerous occasions.
Yes.
And the feature of the Van Mierop part is that the septum runs the full width of the atrioventricular junction. So nowadays, with the 3-dimensional techniques, you can, with precision, determine the proportion of the junction that's committed to either the right or the left of the septum by making the chord of the septum relative to the circumference of the atrioventricular junction. So exactly the same way of approaching overriding arterial valves. And you will recall that you had that infamous debate with Talgeva, where
yes,
he wanted you to look at the long axis of the section, whereas when you're determining the degree of override, it's not the long axis of the section at all.
sure.
It's the short axis of the atrioventricular junction versus the chord of the septum. And now with the 3-dimensional techniques we have at our fingertips, you can do that with total precision. So you could even do it, I do believe you could do 51-49, but we're not going to get into such minimal things. But certainly you can if it's 70-30, 80-20, 60-40, I think you can do it with absolute precision.
I think, yes, but it's interesting that I know obviously it's much easier to take a heart where there's clearly a straddling valve or a double inlet and understand what it is. But the patients that are going to be a problem are going to be in the middle range, and perhaps those patients are more easy to deal with and perhaps haven't come your way into autopsies to the same frequency.
Alan, What's your take on this, having heard the whole thing and with your?
I'm just glad it's recorded. I can watch it again several times.
Guys, can we take a look of Adrian? Adrian has to show us.
Have we found Adrian? Has he
yes,
appeared?
we found him, yes.
Where is he? I can't see him.
Even a 3D printing to show us.
Hey
Welcome,
guys,
Adrian.
I'm gonna have to go.
Okay.
I have 4 ladies waiting on me to go to the beach, so
Well,
I'll see you
enjoy.
next week.
Enjoy your day.
Thank you.
Thank you very much, Diane.
Happy birthday. Oh, well, this has been an amazing session.
Where's Adrian? We've not finished.
Adrian's here. If you can change to presenter's view, you are going to see, to speaker view, you can see only him. Adrian, if you can start to talk and show us.
Hello, can you hear me?
Yes.
Perfect. So I think I've just shown here one of the 3D print models that we've done. And if you look at how the atrioventricular junctions and the valves are, we are million years away from what's happening to the real hearts. I think the technology will come, but we are not there yet. And I think the micro CT probably will make a change. If you allow me to show you the 2 hearts that are a bit rarer, I'll run you through this heart first, which is a 5-month-old child. This is shortly when Mr. Braun came and joined us in Birmingham. It's a 1989 heart. So this child died at 9 months of age. I will first show you the heart because the heart is operated. And if you see in attitudinally correct position, the heart will sit like this. And then if I take you to the right-sided atrial chamber, this is the right-sided atrial chamber. Initially, a balloon atrial septostomy was done, as you see here. If I put my finger to the balloon atrial septostomy, I then go into the left-sided chamber that looks smooth-walled around the vestibule. So this is a left atrium. So again, on the right side, this is the atrium, a morphologic right atrium. On the left side, the morphologic left atrium. This is looking from the base of the heart. Now, there is no exit from the right side atrium for the morphologic right atrium, but it's the dimple, the usual dimple that we see in absent right AV connection. The only exit, it was through the balloon atrial septostomy. And then we come back to this left-sided atrium and we look down into the junction between this morphologic left atrium and the ventricle. If we look at the ventricle, this is a finely trabeculated crisscross ventricle, and it is guarded by its own valve. I wouldn't say what kind of valve is yet, but then to recap, we have a morphologic right atrium on the right that has no connection. Then there is a morphologic left atrium connected to a large cavity that looks morphologic left ventricle. I turn the heart back to the front to show you what we have in terms of great arteries. Now, after the balloon septostomy, the patient went on and desaturated. Eventually, what they did was a CP shunt, a Glenn, and a systemic to pulmonary shunt between the main pulmonary artery and the aorta. So this is the aorta that is anterior. This is where the connection was done between the aorta and the pulmonary artery, which is here. You can see the leaflets here. And this was the connection between the 2 great arteries, the shunt. But let's see where these great arteries are coming from. So the pulmonary artery comes from this large morphologic left ventricle, and the aorta, which is here, comes from a cavity that is located on the left side, is anterior, it's on the shoulder of the heart, is this cavity here. You can already see there inside that there are some either papillary muscle with cords. But if I turn back and I show you from the morphologic left ventricle, you can clearly see now the interventricular communication. And this interventricular communication takes us into that small cavity that is here, that it runs into the aorta. And you can clearly see, I will open that small cavity now again, and you can see how the papillary muscles are running inside. So the valve, you can see here, the valve is actually straddling and probably overriding into this small chamber. And this is the valve seen from the morphologic large left ventricle. So to recap, usual atrial arrangement, absent right AV connection, the left connection between the morphologic left atrium goes into a morphologic left ventricle, which is the dominant ventricle, posterior, and that ventricle gives rise to the pulmonary trunk. And then from a small chamber that looks heavily trabeculated and situated on the left side comes off the aorta. So this is a left-hand ventricular topology referring to the right morphologic right ventricle, but with straddling from this valve that guards the left atrioventricular junction into the small cavity that you see here. And this was the operated heart. The non-operated heart is here. This is a little bit clearer. It's a heart and lung block, just to show you that the apex of the heart goes to the right. But when I read the PM, this is a heart from 1979, unoperated, so naive heart. Apex goes to the right, but the heart was mainly in the left chest, so I wouldn't call it dextrocardia for that intended purposes. Attitudinally correct position, we can see the large trunk that looks like an aorta, which is here anterior, but looking further to the appendages, what looks from outside the morphologic right, with pectinate muscles all around, and the morphologic left on the left side. If I open this cavity, the right-sided atrial chamber, as you see, it goes nowhere. It goes into a dimple, and there is a deep atrioventricular groove on the right side. Where it goes to two atrial communications that are here. One is both are in the flat valve with deficient flat valve here and here. And if I put my finger onto interatrial septum and I go into the left cavity, you can see my finger, and this is the interatrial septum. Now we are here in the left-sided morphologic left appendage, which connects to this ventricle that has crisscross fine trabeculations and is guarded by a valve that you already can see that it's straddling over this structure in my left hand here. So this is the valve, and it's straddling there. Now, if I turn the heart back to the front to look what happens in this cavity, on this side, you can clearly see how the valve is straddling in this cavity that gives rise to the aorta. And the pulmonary trunk is located posterior. It was a severely stenotic pulmonary trunk located posterior. And if I probe that pulmonary trunk, I open the heart again. I need to go to behind the aorta. So this is the entrance to the pulmonary trunk. If I go there, I'll end up into the pulmonary trunk. So it's a very stenotic entrance to that pulmonary trunk. But what is interesting here is to see that that valve that guards the left atrioventricular junction is straddling into this smaller cavity that is heavily trabeculated. So to recap, we have an absent right atrioventricular connection. We have the left atrioventricular connection that goes into a dominant left ventricle, morphological ventricle posterior, and we have this smaller ventricle that is morphologic right ventricle on the left side of the ventricular mass, which means left topology of the right ventricle, left-hand topology. So this is what I wanted to share with you today, because these are both cases of uniatrial biventricular connections with straddling of that single solitary atrioventricular valve. Thank you.
Adrian, that is quite spectacular presentation. I mean, the way your images have come through to us have been absolutely superb, and it shows what we can do these days with Zoom, and your descriptions are superb. And that's exactly the point I was making about the uniatrial and biventricular connection, that the dominance of the ventricles can vary markedly. And it's most, I mean, those hearts, two hearts are quite beautiful. can you go back to the first one again? Because was it also the case that there was the solitary atrioventricular valve had 2 orifices?
No, so this is a solitary atrioventricular valve.
But is there not a band of tissue that's dividing the valve into its separate right and left orifices?
Not as far as I can see.
So go over to your right side. Is that not a separate orifice within the valve?
If I look here, I think I know what you mean. It's here, you mean?
Yes.
It is. Yes, it is here. Let me show you better. Here, it's a small accessory orifice because this will be the left AV junction. Let me zoom in. So the left AV junction, there is this strand of tissue here that will separate this accessory orifice and the larger orifice.
So as well as having a straddling and overriding solitary valve, it's also a dual orifice.
Yes, yes.
The small orifice is also going into the dominant left ventricle.
Yes, absolutely. This is the dominant left ventricle. This is where the septum is. You see balloon atrial septostomy here. And this is where the orifice, but the small ventricle, obviously, it will be here. It's here anterior and left-sided. And you can see here how the cords are crossing to the small cavity.
And this also is one of those hearts that I was talking about. You've showed us beautifully that in both of the hearts, there's left-handed ventricular topology.
Yeah.
So had the right atrioventricular valve developed, it would have been a mitral valve.
Yeah.
Yet, as you show us, when you look into the floor of the right atrium, that looks as though it ought to be tricuspid atresia, but in fact, it is mitral atresia. Because had the valve developed, it would have been a morphologically mitral valve in the setting of left-handed ventricular topology.
The sinus is here. This is the septostomy. Yeah.
Absolutely beautiful hearts, and thank you so much for sharing those with us.
Thank you for allowing me.
Would, if you permit me, I can augment that this discussion from and illustrate this particular case that I talked about in about 2 minutes. So if you let me share my screen.
Go ahead, Dr. Silverman, please.
Here's my screen, and I need to put this into play. This is a fetal echocardiogram. And I'll put it into play here. And you can see here what looks like an AV septal defect. And this is the aorta coming from the right ventricle. There's no pulmonary outlet over here. But what I wanted to show you about this was the pectinate muscles, even in a fetus, more defining this as a morphologically right atrium. But my first impression on this heart was that this was really an AV septal defect. And the reason is that I've made this point in discussion is that the atrial septum is malaligned. And so what you really are looking at mainly into the right ventricle, there's a small ridge of tissue which you cannot actually identify on the scan as you go from below to above. And we were unable to recognize this in utero. I'll just show you the postnatal echocardiogram quickly over here. And this is the postnatal echocardiogram. And you can see here that here is a separate AV valve orifice here. And this AV valve orifice is straddling across the ventricular septum, almost 50%. You see also this characteristic feature, what I've found in these patients is the narrowly spaced papillary muscles within the morphologically left ventricle in this patient. And then I'll just show you this over here. Let me just put this up here like this. And here you can see the aorta rising from the right ventricle. The reason you can see the small morphologically left ventricle, the large right ventricle over here. And you can see that there are bilateral arterial ducts, each supplying a separate pulmonary artery without an anterior artery in there. And then if you look at, I just want to put this in here. This is very important to look at this here. Here is the CT scan. We're starting to see morphologically left ventricle here. You see the two narrowly spaced papillary muscles coming into play here. There's the right ventricle now here. And we'll get to see the ventricular septum in a moment. There, it's disappeared here. So there's the interventricular communication. And here you see the right atrioventricular valve orifice. This is what I was saying the strength of CT is. You see the right atrioventricular valve orifice, and here is the left atrioventricular valve orifice straddling the ventricular septum. So I think that as a combination of techniques, we were able to, treat this child, and this child got a single ventricle repair, a cavopulmonary anastomosis, and unifocalization of the pulmonary arteries into a shunt, and eventually into a Glen, and this was very well handled. But you can see how we missed this diagnosis in utero by assuming that, like everything else, that straddling valves are always AV canal defects, and they weren't.
But
So
I mean,
I'll stop sharing that.
That's exquisite. I mean, one wonder you had the suspicion in your mind that you were going to need the CT scan. So why did you bother with the echo? Why didn't you just do the CT?
Bob, well, Bob, the patient got born, and the patient had a SAT of 89 initially because of the bilateral ducts, and there was no urgency. And I think clinical process is always to go and see what you can see. And we discovered that there were indeed two separate atrioventricular valves.
So you did in fact make the right diagnosis with the
yes,
echo.
well, we made the right diagnosis of a straddle after birth.
Right.
So
But you were suspicious of that even before the fetal echo. You knew there was straddling. As you say, you couldn't see for sure whether it was two valves or a common valve.
Yes, but I think that the problem that I can show you an autopsy on another patient where you just see a little septal rim, and it's so hard to recognize it. But indeed, you can see the valvar tissue very clearly, and there were clearly two separate AV valves, and the valve was associated with straddle, which you could see. This was not an AV septal defect. Okay, and then the CT scan, which I must tell you that the CT scan read by the radiologist did not go into the separate atrioventricular valve orifices that you can see on this here. This is something that I've defined by looking at this 100,000 times on this particular patient. But I think the strength of the CT or the three-dimensional simulated techniques, whether it is MRI or CT, is to look at the valvar orifices, then the annuluses of the valve. And clearly here, there were two annuli of the valve, and the one was straddling across the ventricular septum.
Stop sharing your screen anymore, and we can all come back.
Okay.
There we go. Beautiful.
Guys, this session, really amazing. A lot of nice input from all of you. We are really, really thankful. We've been here for 2 hours already. This was amazing. I think that's the longest one that we had. Unfortunately, we won't have time for the questions, but I'm sure everybody learned too much today. Thank you very much. Hope to see all of you next week. It was really amazing.
Thank you, Grace. Thank you, Bob. Thank you, Diane. In absence.
Thanks to Q also. It's good to have a surgeon on board. We hope we'll have you here in subsequent weeks.
We'll try to attend surgical scheduling permitting. We'll see.
Yeah. Okay.
Thank you very much, guys. It was really great. Bye-bye. See you next week.
Bye. Hello, Maria. This is Dr. Norman Silverman.
Yes, I know. But I think this is right now it's 5 p.m. Yes?
Yes, so we're going to do 7 p.m., right?
Yes.
Okay, I'm waiting for you. Are you going to send me a Zoom link, or what are you going to do?
Yes, I already did this a couple hours ago.
Okay, I haven't looked at my email. I've been in a meeting with Bob Anderson this morning, so I haven't had a chance to look
Okay.
at